Morning or good afternoon, depending on where you are. Thank you so much for joining us today. My name is Emmy Betts, and I serve as the Deputy Director for the Injury and Violence Prevention Center here at the University of Colorado Anschutz Medical Campus. Today's presentation is part of our monthly Research2Practice webinar series, where we present topics in injury and violence prevention. And our webinar today is co-sponsored by the College of Nursing and the Rocky Mountain Prevention Center, also both at the University of Colorado Anschutz Medical Campus. So before I introduce today's speakers, I want to go over a few logistics. So first, this session is being recorded, and we will send out that video link to everyone who registered. We'll also put in the chat box the link for other past webinars if you want to look through our prior series. We'll have a time for moderated question and answers at the end. So please put any questions in the Q&A box at the bottom of your screen. And then we hope you'll come back for our other webinars. This year in 2021, they're each month on the second Tuesday of the month at this time at noon Mountain Time. And next month in July, as it heats up, we'll be cooling down with a session called Safer Slopes, Trauma Data, and Ski Patrol Perspectives on Preventing Ski and Snowboarding Injuries. So we can all look forward to winter. But now it is my great pleasure to introduce today's speakers. Our session today will focus on understanding the impact of early life stress and resiliency with both research and practice perspectives. We know that exposures to adverse experiences early in life can have lasting impacts on health and well-being across the lifespan. And in fact, those impacts can even span generations, which is why it's so important we consider them both from a research perspective and practice perspective. So our first speaker today is Dr. Hector Olvera Alvarez, who is an associate professor and senior associate dean for research at the School of Nursing at Oregon Health and Science University in Portland. His research focuses on understanding how social and environmental factors interact and drive health disparities. Current work includes experimental and epidemiological research on human exposure to nature and its impact on health. Today, Dr. Olvera Alvarez will present a framework for understanding the ways in which stressors correlate and are moderated by low socioeconomic status. And then after him, moving from research to practice, we'll be hearing from speakers from the Office of Early Childhood at the Colorado Department of Human Services. They're going to describe services provided to families here in Colorado that attempt to counterbalance the impact of stressors and build resilience in children and families. They'll be co-presenting, it'll be Erin Miller, who's the Family Strengthening Director in the Office of Early Childhood's Division of Community and Family Support. His position provides leadership for the state's family strengthening programs, which include home visiting, family resource centers, and the primary and secondary child maltreatment prevention programs and strategies. He serves as the state lead on the Strengthening Families National Network and as a co-chair of the Colorado Strengthening Families Network. He's previously led two state-sponsored evaluations of the Colorado community response to understand the effectiveness of the program for preventing child abuse and neglect. And joining Mr. Miller is Esmeralda Santillano, who is the Family Resource Center Program Manager, also at the Office of Early Childhood. In her role, she is the community-based child abuse prevention state lead, and she supports programs to enhance family protective factors across the state. Prior to joining the Colorado Department of Human Services, she was responsible for the development and delivery of child maltreatment prevention programming and services for the city and county of Denver. She also previously served as a bilingual licensed professional counselor, a role in which she developed and implemented culturally responsive behavioral health programs that focused on reducing the stigma of behavioral health among culturally and linguistically diverse communities and in increasing their overall wellness. So thank you again to our speakers for joining us. For the audience, as a reminder, please put any questions into the Q&A box for our moderated session after the presentations. And now I will turn it over to Dr. Olvera Alvarez.
Thank you, Emmy, for that introduction. Again, first of all, thank you for inviting me. I really like to talk about my science, but specifically when it comes to ACEs, which is what I'm going to talk to all of you today. I'm going to just get started because I have a very dense presentation and I want to make sure that I stay on time. The agenda for today is that the first half of my presentation, It's going to be a very dense overview of the literature. I'm pretty sure that most of you are aware by now with early life stress or ACE literature, but I just want to condense them for just to remind everybody about it. I'm really going to talk about hypotheses, pathways, and frameworks about how early life stress leads to disease and ill-being later in life, and how ACEs can be thought as a key determinant of health disparity. So I really want to frame exposure to early life stress as an essential element, an essential stressor of driving health disparity. And then the second half, I'm going to talk about some research. Specifically, I want to focus towards the end. I did some post hoc analysis on some of my work, looking for protective factors to land my presentation on. That comes at the end. I do want to give a heads up that because I have very little time and I want to present a lot of things to you, I'm going to go very briefly over the methods of the studies that I'm going to present. But if you have questions about that, feel free to reach out to me or ask during the Q&A session, and I'll be glad to clarify anything there. Again, I don't mean that as a lack of respect to any of you. Again, thank you for that. So just to remind everyone, or for those that this might be new, the idea of early life stress or childhood adversity came from a study from Kaiser Permanente and the CDC in 1997 that asked these 10 questions. There were 3 about abuse, physical, emotional, and sexual, 2 about neglect, physical and emotional, and 5 about household dysfunction, those that are there. These were yes and no questions. If you answered yes, that means you were endorsing exposure to that stressor. Therefore, the score would be the sum of yeses. So a yes would be a 1. So the maximum score would be a 10. The minimum score would be a 0. That means you were not exposed to any of them. Since 1998, when they published their first study, there has been a lot of associations with a lot of adverse health outcomes, health problems, health behaviors. I'm going to list them in the next slide. But I do want to mention that they're ubiquitous. Adverse childhood experiences are ubiquitous in the United States. At around 2/3 of the population have at least one. Around 16 to 17 to 18%, depending where you are, have 4 or more. Now, 4 or more, I'm going to use it as a threshold throughout the presentation, mostly because that's really when the associations or the predicted capacity of ACEs with adverse health outcomes starts to happen. So you're going to hear me talk about about 4 or more, and that's why I'm doing that. Again, in terms of health outcomes that have been associated during the last 20 years with ACEs, I'll start with injury. And the risk of injury is higher. Mental health, anxiety, suicide, depression, it's higher with high ACEs. Unintended pregnancy and pregnancy complications, maternal health problems are associated with ACEs. Infectious disease, chronic disease. In the chronic world, you name it, it's probably associated. Then, of course, risky behaviors. When we think about people that have adverse childhoods, we immediately associate that with certain health behaviors. Binge eating, binge drinking, unsafe sex, for instance, would be at the very top of the list of what's documented. And then, of course, the socio-economic problems that come with those adversities, those behaviors, those health risks affecting education, occupation, and income across the lifespan. If ACEs is something new to you or you're looking for a good resource, the starting point for sure is the CDC website on ACEs. There's links to the original study. There's links to data that the CDC is collecting, that the states are collecting. So that would be a great resource to start with. A point that I want to make, I think for most of the audience, I expect that all of you are, or most of you are familiar with the ACE literature. So I want to talk about one key aspect that is less known about it, because this has been emerging during the last 5 years or so regarding the pass down of the transgenerational pass down of risk. So I'm going to mention in this sort of cartoonish way a recent study, well, like 5-year-old study that I read that fascinated me about the possibilities of this transgenerational pass down of the risk. The study was conducted in animals, it was conducted in mice, and the study started with a cohort of mice that were genetically identical or very similar. They divided them into randomly, so they had 2 groups, the control group and then the exposure. The exposure group, the exposure consisted of stress during adolescence. That's 2 weeks after they were born. For 2 weeks, for 2 hours every day during those 2 weeks, they were exposed to a stressor. They actually put the mice in the cage of a cat. The mice were in a cage. The cat couldn't do anything to them, but you can imagine how stressful that was. Then they stopped the exposure. It was just for those 2 weeks. They waited until the mice were adults. And what they observed is that the mice were more likely to exhibit depressive behavior. At the time of this study, the association between early life stress and depressive behavior in adulthood was not new. It's actually depression and ACEs is one of the most robust associations in the ACE literature. I'm actually going to refer to it later on a lot because I consider it almost a keystone association of ACEs. But this is where it becomes very interesting. All of the mice, by the way, were male mice. The male mice had offspring. And socially they had no interactions. The dads with the mice did not had with the offspring did not have any interaction. All the mice had the same experience as the control experience originally. So everybody had an awesome life and adolescence as well. And what they observed in the offspring mice that during their adulthood, the ones that came from parents that were exposed to early life stress, they also were more likely to exhibit depressive behavior in adulthood. So suggesting a couple of things. One, the transgenerational Passdown, and the other, some sort of potentially epigenetic process priming the risk. Something that I'm very interested in is not only early life stress, but stress in general. I could talk a whole hour just about stress. Sadly, I'm fascinated by it. But I want to point out a couple of things that we think are going on about stress and why in early life it's so toxic. Not all stress is bad, by the way. So in this picture, the two subjects are experiencing stress. One is obviously good, the other one is toxic. If the subject on the right survives, the stress that this type of circumstance induces is more toxic because of two key reasons. One, they don't have control over it. And second, they have less coping mechanisms to deal with stressors that they don't have control over. The subject on the left, of course, this is stress that is self-induced. Therefore, it implies the capacities to cope with that stressor. So it's about control and it's about coping. So when you think about early life stress, child, especially humans, we have no control over our stressors, making those stressors toxic. And second, our coping skills and strategies are very minimum or not existent. Therefore, we have very little coping capacity, which makes that stress toxic. The other thing that it's going on with stress early in life is that it seems to be trading off survival for longevity. If you go back to evolutionary biology, the purpose of life is to pass down its own genes. Therefore, if we perceive early in life, organisms that perceive early in life stress and adapt well enough to survive an adverse environment long enough to pass down their genes, they're more likely to keep their genes in the pool. In other ways, phrasing in the improper way, those of us that are more capable to do that adaptive process of responding to a stressful early life environment by changing our biology to keep us alive long enough to procreate, we are more likely to remain in the pool gene. And that's why those processes are currently in humans. But what is going on is that we change our neurological system, we change our immune system in a way to promote survival, to keep us alive right now. But what we're trading off is that umping up of our defense mechanisms has a wear and tear in our body that get us sicker sooner and has a worse prognosis on our health. So there's a price we pay to survive because of stress. The other thing that's going on, as you go through the literature, it's evident that there's a sort of phenotype that it's being sort of described in the literature. There's several things that are aligned with this ACE phenotype. And I'm going to mention them all, but one of them includes early puberty, for instance, and females specifically. And again, as you look at that, it goes back to the survival argument that I'm making, that all the changes that seem to be happening seem to promote survival rather than longevity in health. And again, survival has a wear and tear. The ones that I really want to focus here are threat sensitivity and reward processing deficits. These are two traits that I consider part of this ACE phenotype. What do I mean by threat sensitivity? Well, two things, hypervigilance and hyperreactivity. Both of them have to do with stressors. Hypervigilance, it's this, it was I found this in a paper that was looking at how people responded to faces on the screen. So there were happy faces, there were sad faces, there were mad faces, and there were neutral faces. And that was really the experiment, the neutral phase. So people that had high ACEs or high early life experience were more likely to endorse the neutral phase as an angry phase, as a threatening phase. What that means is that people that are reared in early life stress are more hypervigilant. We're looking out for stressors, we're looking out for threats, and we're hypervigilant. And what that means is that we're more vulnerable to stressors later in life. Why? Because we're more actively looking for them, and we can more easily endorse something as threatening. That means that given the same circumstances, somebody with high early life stress is more likely to be exposed because they perceive more stressors across their lifespan. That, of course, has wear and tear. And then hyperreactivity has to do with neuroimmunological processes, that what it does is that for every stressor that we're exposed, in this case, psychosocial, our immune system responds with a higher inflammatory response to the stressor. We have seen this with actual psychosocial stress, where people later in life that are exposed to acute stressors, those that were also had high early life stress, their immune system produced more pro-inflammatory cytokines for that stressor. We also see that with virus and bacteria. People that have high early life stress, when we expose their white blood cells to LPS, for instance, later in life, their white blood cells produce more IL-6, more TNF-alpha for the same given exposure. So we know that there's a hyperreactive immune system that goes part of the phenotype. Then when we think about high ACEs, we also think about risky behaviors. Again, poor eating behaviors, drinking, addictive behavior. And that's actually the very easiest way to explain how these early life experiences lead to these diseases later in life. But it turns out that there's a hypothesis that was published a couple of years ago by Nusslock and Miller. And by the way, that's the wrong reference. I apologize for that. This was published by somebody else, Nusslock and Miller, and I can share the reference if any of you are interested. But what they're proposing is that hyperreactivity, of course, leads to low-grade peripheral, chronic low-grade peripheral inflammation over time, because we accumulate that inflammation. That leads to, it also stimulates the microglia in our brain, that also produces inflammation, that then changes our reward sensitivity mechanisms in our brain that lead or explain or are associated at least with some of the risky behaviors that we see in ACE phenotypes. So again, this hyperreactivity, this hypervigilance, and these behavior changes, that all of them explain the wear and tear that happen in high early life stress groups, are associated and linked through an inflammatory pathway. Now, what I'm interested, the way that I stumble into this is that I'm very interested in health disparities in minority groups, especially socially disadvantaged groups. So obviously the starting point are the social determinants of health, which I think are fascinating. I worked at a school of nursing, and I see the value of the social determinants of health have in clinical settings. It helps primary care providers to really get to know their patients and really identify determinants that are beyond their control, but that are important to providing good care. So I value them a lot. However, for research, they're kind of fuzzy. Again, if you look closely, this in reality, the social, community, neighborhood, and environment, all of them are really just talking about the environment, both the social and the physical, but it's separated in different ways. And then of course, social disadvantage, it's embedded in all of it across. So again, from a research perspective, it's very complicated. Something that I'm interested, however, it's in these two, in the environment, both the social and physical, and I'm interested in the interaction between the two. So ACEs was a perfect way to start thinking about how being poor affects the way that I respond to the environment, which is the way that I stumbled into this field. I did that by, the first thing I did when I became interested in this is like 8 years ago, is that me, a couple fellows, and a mentor from a fellowship, we developed first a model to be able to study these things in a more, to help design studies to think about these things in a more comprehensive way. So we came up with this model. Here's the citation, but I want to emphasize a couple of things. The way we frame this is, okay, we are all embedded in an environment, social and physical, and that these exposures lead to biological and behavioral responses. Again, very obvious, very linear, but sometimes something bad could lead to something good. I have seen a couple results in my own studies where adverse ACEs lead to weird protective outcomes, and I'll mention that later if I have some time. But the point is, These behavior and biological responses, which of course are connected, lead to either health or disease. What I really want to focus on are these resource and susceptibilities, right? This could be a biological resource, it could be a social resource, and the same for susceptibilities. The point is that this process right here of how the environment translates into a biological or a behavior response is not always the same for individuals, right? There's a lot of individual variation, and that a lot of it can be explained by this set of resources and susceptibilities. And this is what I'm very, very interested in. And because that's the way that I think ACEs and the world and the environment might be associated. So I'm going to give you an example. So in the social context, the social environment, that's where ACEs live. And again, this model looks across the lifestyle. So early in life, we're exposed to stress. As suggested by Newslog, there's an epigenetic process that changes the way my brain works, the way that my immune system works, and it creates a susceptibility. It creates a susceptibility to other stressors, and it creates a susceptibility to bacteria and viruses. Now, the physical environment, again, people that are also socially disadvantaged also have adverse physical stressors, including air pollution, for instance. So what I was wondering, given that there's this epigenetic imprinting to make the immune system hyperreactive, and because air pollution, specifically traffic-related air pollution, acts primarily through the immune system, I wonder if there was this interaction here that was leading to a biological response that was leading to disease. In an article in Neuroscience and Biobehavior Reviews, we published this hypothesis. This is an application of the ISOM model specifically to this problem. Here I propose a mechanism. We're going to skip it for the sake of time. The first set of results that I'm going to show you are from an epidemiological study that we conducted in El Paso. This is the Nurse Engagement and Wellness Study. It's a study of 500 nursing students. We collected a lot of data. Primary focus was ACEs and the way that people respond to the environment. So we have traffic-related air pollution and traffic-related variables. What I'm going to show you the first set of results, I'm going to focus on the graph on the right. Traffic intensity, again, is not air pollution, but it's a strong surrogate of air pollution, probably the primary predictor of air pollution exposure in an urban environment. And serum amyloid B, which is associated with chronic inflammation, and is also likely a predictor of cardiovascular risk. As you can see, having one ACE or more, all the way to 4 or more, leads to a inflammatory association with traffic intensity. This was measured at 250 and 500 meter buffers around participant homes, whereas the low ACE score actually has an inverse associations. We don't have a clear explanation for this. My first hunch is that because they have a healthier or just an immune system that is primed in a different way, they are actually triggering more strongly their anti-inflammatory processes that follow inflammatory processes, and that might explain this association going in the other way. But the point being, there is in fact a ACE-induced change or response to the environment. Of course, that's cross-sectional, and we needed more experimental data. So what we did is that we conducted an experiment. We recruited healthy university students, and we exposed them to levels of pollution that are similar to those that people would experience during a morning commute. So we went near our highway, we stayed there, we exposed our subjects for 2 hours to the exact same air that this person right here is breathing. We thought that that should be enough to induce an inflammatory response. We have a lot of results, but I'm just going to show you one graph, which is the one that really has to do with the presentation. We divided the groups, first of all, in 2 groups. We measure the inflammatory response 1 hour after the exposure and 24 hours after the exposure. We looked at 4 inflammatory markers, IL-1 beta, IL-6, IL-8, and TNF-alpha. We divided the groups in 2. Those were ACE greater than 3, that means 4 or more, or 3 or less, and here are the results. At 1 hour, the 3 or less do not show an inflammatory response at all, which is, by the way, the feedback that I got from experts when I was designing the study. They told me that the exposure level that I was going to use was too low to induce an inflammatory response. And in fact, if I combine these 2 groups, the effects are new. What we're seeing was that only the high ACEs had the inflammatory response. So again, the results did coincide with what my mentors predicted was going to happen, but what everybody was missing, which is the point of the entire study, is that this subgroup is susceptible to the things they're vulnerable to. And therefore, we miss them. By studying social factors and environmental separately, we're missing this group, and therefore we're missing this vulnerability right here. That was the entire point of the study. We see that at 24 hours, the effects are still there. They're not significant anymore, but they're approaching significance. I'm pretty sure if the sample had been greater, this would have remained significant in 24 hours. So take that with a grain of salt. Now, looking at protective factors, I'm very interested in nature exposure, especially that now that I'm in Oregon. In the literature, by the way, most of the studies are done in places like this. I wanted to see if in El Paso, nature had a similar effect than in these other places. One of the primary health factors associated with green space is fasting glucose. So we looked at that. We look at different buffers around people's homes. I'm just going to show you one. This is immediately next to your home in El Paso. If you're in El Paso, on 250-meter buffer, and we see a significant effect on fasting glucose. Now, that's not what I want to show you. What I want to show you is that high ACEs do not have the same benefit. So low ACEs are here. That's the red line. This is greenness. This is glucose. The more green, the more reduction in glucose that they experience. We still see an association for medium and high early life stress, but we don't see it as strong as for low. So far, they get hurt more by air pollution. They benefit less from nature. Now looking at protective factors, which is what I really wanted to show. So here, this comes from the new study as well. We're looking at ACE and depression. I told you that's sort of a keystone association between these two. First, we looked at forgiveness. This is a scale that measures how skilled or willing or capable persons are to forgive themselves, others, and the situations. It puts together a score. So this is a very forgiving person if you're high, not so forgiving if you're low. We see a main effect, but we don't see an interaction. It still benefits to develop these skills because it would lower your risk of depression. But again, the effect of ACE on depression remains the same, meaning the slopes are the same. Then we looked at social support. This is how many people around you are capable to, you feel that would support you if everything went wrong in your life. So this is your social safety net. High would be people that feel that they have a good social safety net. Low tertile would be persons that feel that if they lost it all, they're on their own. Now we see that there is a main effect, but more importantly, there's an interaction. It is approaching significant. So we're hopeful here that social support might actually start to counteract the effect of ACE on the risk of depression. So not only help you with it, but actually counteract by changing the slope of the association. Next, we look at sleep duration, how long your sleep is. Sadly, we didn't see anything meaningful. Here, there's something approaching significance, but again, you would have to dig very deep. However, when we look at sleep quality, again, top, very good quality, bottom, very bad quality, same association, good quality, not only has an interaction, almost erases the effect of the association. Grain of salt, cross-sectional, only nursing students, only El Paso, mostly Hispanic, mostly females. So a lot of limitations there, but at least something to be hopeful for and looking in the right direction. Last thing I want to show you is a CBPR study that I did with a leadership academy that I used to direct. The sample is small, but it's very interesting. We looked at depression, we looked at ACEs, and we looked at parental attachments between the children and their parents. And what I want to highlight is that those that had high attachment, again, the same thing as with sleep quality, the risk of ACEs on depression almost goes away. That would be this low line, blue line. Whereas if the attachment is low, the association remains strong between ACEs and depression. I apologize for the weird graph, but I hope the message is clear. So the take-home message is that individuals in social disadvantage due to higher ACEs experience greater health burden due to social determinants of health. That's clear, but includes the environment, that interaction there. They also experience less benefit from positive environmental exposures, like from nature. And we have, however, social support, parental attachment, sleep, and forgiveness could be protective pathways to counteract the susceptibility induced by ACEs. So there's hope not only to help people be less affected, but actually counteract the risk induced by ACEs. There's a lot of work to be done. This is just a start, but again, some hope there. These are all the people that helped along the way, and I'm going to pass it down to Esmeralda and
Thanks, Dr. Alvarez. That's very good research, very promising, and it certainly aligns with our beliefs and the works that we're doing here in the Office of Early Childhood. So we came to talk a little bit today, my colleague Esmeralda Santillano and myself, about the protective factors and how they're embedded and woven into the work that we do in the Office of Early Childhood to when we're working with families to kind of offset some of the things that Dr. Alvarez talked about around the ACEs and the impact of ACEs on children, and how can we help to buffer those things. So as if you go to the next slide, please. So just in general, the Colorado Department of Human Services, we are people who help people. We really find value in working with families throughout the entire department to provide resources and supports that ensure that children and families have the things that they need to thrive. So next slide. So going off of what we heard from Dr. Alvarez a little bit today. So this tree here, it really illustrates the adversities that can be experienced in the community level, at the family level, and the leaves are intended to represent, the adverse childhood experiences that an individual might experience. So when you think about the soil, the loose soil, and the impact that has on the tree, and all the environmental effects that are going on in the environment, and the impacts that it may have on children and families, it really kind of creates that picture of how the ACEs and the impact of the ACEs scores and the environment really impacts the children and families. So we talked a lot today about the stressors, the impact, but looking at looking at the social ecological model lens, and particularly around some EDI work. I know we're all working to move the needle on some EDI work, but using this as a framework. But thinking about the supports that we have available, how do we think about these stressors, both at the community level, at the state level, and at the individual level? What can we do as a system to offset or counterbalance those ACEs? So, as if you go to the next slide. So again, we rely heavily on the protective factors. So there are 5 protective factors known through research-informed practice that are shown to reduce the prevalence of child abuse and neglect, which is where our focus is. But we also talk about it in the sense of kind of buffering those ACEs. But there's research to show that if we can increase the characteristics, those 5 protective factors for families, that the prevalence of child abuse and neglect goes down. So those 5 protective factors that we work on. So some of our programs, they all embed the framework into the work that we do. So it's nice. We often get questions around how do I start that program, the protective factors, and it's not a program. There's no cost associated with implementing the framework into the work that you do. It's really this framework that should help guide your practice and help you think about the things these characteristics that we can help increase for families that will kind of buffer some of the things that we've talked about today. So the first being parental resilience. How do we help families manage their stress? How do we help them identify when they're managing stress so that they can use those coping skills to increase those characteristics in other situations where they may be experiencing life stressors? Social connections, we truly believe, and I think Dr. Alvarez's research that he showed there, that social connection and just how important that is for families and for all of us, really. I think that really became more prevalent for me during COVID, like when we had to social distance and isolate from those relationships that we had, those social connections that we had. I could see the impact that it was having on me and it was having on our families. And so we can certainly identify and see the importance of building those healthy social connections. Knowledge of parenting and child development, helping parents or caregivers understand child development, parenting strategies, and connecting them to the resources and the supports that they need back in their community when they do have challenges or concerns. And that could just be connecting them back to a parenting group where they're talking about child development so that they hear from others in that same group around challenges that they might be having, and kind of normalize some of the things that may be going on. And then we also really work on concrete supports. That was another one that really became evident to us during COVID, and how that connection to the concrete supports back in their community. Where do you go when you are trying to access a food bank? Do you know where the food bank is? How can you find the food bank? I think one of the one of the things that we really found, so when COVID was really kicking off for us a little bit, we talked to families, what were the things that were missing and what did they need? And we found that most families were saying they needed access to formula wipes and diapers. And so we worked with FEMA to bring in those resources for families and distributed them through the Family Resource Center. And, so we were able to buffer that for families by connecting them back to those social connections or to those concrete supports in their community. And then social emotional competence of children. So as we're working with the caregivers, we also want to be cognizant we're working and thinking about how do we help children to develop those same skills, those same positive relationships that we're working on with the family to develop as well. So those are the 5 protective factors. Oftentimes when we talk about it in the sense of the protective factors framework, I find that people tend to often overthink it, like, how am I providing the protective factors? What do I need to do to do those things? And my response is often you are doing it and you may not be aware that you're doing it. So really thinking about those characteristics that we want to increase for families and how do we work together to identify them, make the family aware of those things, and then help to increase those characteristics. So let's see if you'll change the slide. So in the Office of Early Childhood, Division of Community and Family Support, and then within our unit, the Family Strengthening Unit, we have 11 programs that we administer either through the home visiting side or the family support side. And so I'll touch on each of them briefly, but what I would say is if you have questions about any of our programming, you can reach out to either Esmeralda or myself, or you can go to our website, Colorado Office of Early Childhood, and you can get some information on where these programs are available and in which communities and who to contact in order to connect the family with those services. So the Colorado Community Response we'll talk a little bit more in detail about, so I won't go into that very much right now. But essentially, it's we're working with families that are kind of deflected from the child welfare system that were reported for concerns around child abuse and neglect, but through the process were identified as not needing services through child welfare. So we connect with them, find out what's going on, and we try to buffer and provide services that would reduce whatever the risk is going on at that time. We have the Incredible Years Home Visiting, McV Home Visiting, Hippie, and then Parents as Teacher, which is all of our home visiting models. They have different criteria and who's eligible to participate in all of those programs. So if you're interested in any of those, again, I would encourage you to check out our website, and it will give you the eligibility criteria and the local community providers where you reside that you could connect the families with. And so if you go to the next slide. And so those are the programs that we offer. We also offer just a few more, Safe Care Colorado, which is really working with families around parent interactions, child safety, and knowledge of parenting and child development using the Safe Care model. So we have that, and then we have Promoting Safe and Stable Families and CBCAP, which are really not programs, but funding streams. So we fund a variety of different programs within our office, really aimed at, how do we work with families to increase their well-being and offset some of the risks that they may be experiencing that could ultimately result in child welfare involvement or disruption in their family or within their community. So one of the programs that we started back in 2014 was an innovative practice. It's the Colorado Community Response Program. And we're really looking at that socio-economic and the factors and how do we work with families where they are. So this program actually brings in families who have been referred to the child welfare system. So they've had a report to the hotline. The child welfare system reviewed it and determined that based on the information available, it didn't rise to the level that they were going to provide services, or they assessed it, they went out, met with the family, there were no safety concerns, but they may have identified some risk factors. They assess it and close it and don't provide services. These families, a very small percentage, unfortunately, get referred to us based on our funding, but they get referred over to Colorado Community Response. We engage the family and we talk about those things. What are the stressors going on in your life? What are the things that you believe someone may have reported to child welfare that kind of got us here today? Because we don't know in the program. So we really work with them using motivational interviewing to talk about like what's going on in your life. And then we start to develop a plan from there, some goal setting. We know that providing economic supports to families is a great stress reducer and creating that equity piece. So we have in this program, we provide a flex funding. So we can provide financial assistance to families that other programs can't. So we really focus in on if this identified risk or need wasn't met, then child abuse may occur. So we tap into this flex funding. We've purchased things like refrigerators, which is something that most programs won't do. But when you get to work with the families, and a really good example is we were working with a family who, they were going out to eat every day at McDonald's because they couldn't keep fresh food in the fridge. So we worked with them, kind of rebudgeted, talked about nutrition, savings, and then we purchased them a refrigerator and kind of helped them create that long-term strategic plan. So again, this program really focuses on how do we increase the protective factors for families. Some of our programs, again, administer the protective factor surveys and some do not, but in this program we do. So we did an evaluation of the program from 2014 to 2018, and we found that families who participated in the program actually did better or fared better than those who did not participate in the program related to some child welfare outcomes. So those that participated, we found that they had a lower risk of being re-reported back to the child welfare system, and they had fewer families came back into the child welfare system at a later date and ended up with their kids in out-of-home placement. And then for the protective factors, we found that the program increased all 5 of the protective factors for families with a strong emphasis or strategically significant improvement in the social connections, concrete supports, and resilience. So really kind of the basis of the model in going in and providing those connections to resources for families, going in and talking about their financial well-being, and then connecting them back into their social connections, both within their community, and sometimes it was helping them to repair some social connections that they may have had with their family, and all of those things, and kind of highlighting the importance of those things. So we found that program worked, and for preventing child abuse and neglect, and that we were able to increase those protective factors for families. We're currently doing a second study of the program, which we're super excited about. It's a randomized control trial, which our data collection ends the 30th of this month, and then we will look at those families that participated over the last couple of years to determine, again, did we prevent child abuse and neglect from occurring? Did we increase the protective factors for families? And then what were the outcomes for those families? So super excited, and we'll publish some findings around that later. And Ezzy, if you go to the next slide. Did that advance, Ezzy? Oh, I missed it, sorry. So again, one of the focus of this program is to address the link between poverty and child neglect. And so we're always really careful to say that families that are living in poverty don't intentionally neglect, and often don't neglect their children, but there is a correlation between poverty and the occurrence of child abuse and neglect. So how do we go in, work with those families, provide resources, support, connect them to the resources that are available to help offset some of the risk that they may be experiencing based on their environment. And then we really work to promote those safe, stable, nurturing relationships with children and their caregivers, so that children can reach their full potential. And then, of course, the kind of the backbone, or one of the things that we really focus on with these families, is their financial well-being, and their how the lack of financial resources could impact financial stress, and how do we help offset or buffer some of those things as well. So, Ezzy, next slide. So the model, again, we touched on it briefly. It's really motivational interviewing. We're trying to move the families along that change process of identifying some areas of growth or things that they want to work on. We do the family strengthening lens, so we're really coming in from that perspective of not a deficit base of what's wrong, but what's going right. What can we do? What can we capitalize on? And what's going right with your family, so that we can help use that information to help inform the participation in the model. And then we really are trying to move families towards, we're trying to move away from that word of self-sufficiency and going to well-being. So how do we create this well-being system for families so that they have the resources and the support that they need, so that their family is doing well and thriving? So that's the Colorado Community Response Program. Ezzy, if you go to the next slide. So our theory of change is that, if we can engage families early on, we're even trying to get further upstream in this program to say, like, let's not wait until they've been reported to child welfare. Let's start bringing in families who are identified through our community partners as having some risk factors that would allow them to participate in the program. They can now refer the community a certain percentage of their families to participate in this program, but we're really trying to engage even further upstream. How do we catch those families and prevent that call from ever happening? But we come in from that strengthening families approach. How do we help them increase those characteristics, those 5 protective factors? How do we help them build some social capital? So we do some social capital building activities, really connecting the families back together and creating that system. Like, we all have things that we can give into the system, and sometimes we all have things that we need to take out of the system. And so it's that system of reciprocity. How do we give and how do we take from that system so that we create a better environment for our children and families? Again, this financial stability and improving family functioning across our well-being domains. So we have 14 domains of family functioning that we measure. Those are things like housing, income, transportation, food security, some of those key environmental factors and family factors that may result in some risk factors for children. But we work with those families in those 14 domains to see if we can provide resources and supports to increase their family functioning in those domains. And then, our overall hope is that we are reducing the prevalence of child abuse and neglect, and that we are providing the resources and support for families to be able to increase those 5 characteristics and help families to thrive. Nancy?
Thank you, Aaron. So I will go ahead and talk about the family support services, or the family resource centers that the Office of Early Childhood supports. So what we utilize is a family development services model where it's more upstream in the sense that any person within the community, whether they have children or not, can go to their local family resource center, identify that they want additional supports, which is the family development pathway, and receive case management support. So really looking at this family-centered approach of providing a safe, welcoming environment that supports all families in achieving their goals. Similar to CCR, it is very much family-led. So the family development worker or the family advocate that their title is, really works with the family on what are the areas that you want to focus on in the moment. With COVID, as I'm sure it's nothing new to the audience, a lot of families went to family resource centers or other local organizations to receive basic needs support. So within the last year, we have 12 family resource centers of all the 32 family resource centers across the state that are funded through family support services. And they engaged about 800 families in the family development pathway, but as it related to basic needs, served over 8,000 families, whether it was diapers, formula, rental assistance, or just any basic needs because of, or as a result of losing work or other aspects, having health concerns due to COVID, things such as that. So similarly, we do offer the CFSA 2.0 to measure how the family is doing in those domains that Aaron mentioned, and really looking at what sort of service delivery do they need, either within the family resource center or within the community. So really linking them. This year, we intend to fund an additional 10 family resource centers to provide this work, as we are seeing that families still continue to need supports as it relates to those concrete supports or even social connectedness. So that is a second program that we offer within the Family Strengthening Unit. I do want to talk a little bit about the Colorado Strengthening Families Network. It is a statewide network to increase awareness of strengthening family protective factors and encourage efforts to embed the work in working with families. Aaron is the co-chair of this, but have definitely worked with the child welfare system to embed the protective factors in social casework practice to ensure that when caseworkers are working with families engaged in the child welfare system, that they are able to identify and utilize those protective factors to create those social and family supports. And lastly, there is a protective factors curriculum that is developed in the PDAS, which is a statewide training system for early child care providers. And that would align with the rating of those centers as well. So currently there are about 1,000 members in the Colorado Strengthening Families Network. And we do have a link if anyone here is interested in participating in that, in this network. So those are the things that we have for today. We want to thank you all for listening to the work that we do. And if there are any questions, please feel free to contact Erin or I.
And I'll just add one additional thing that came to mind. So if you're interested in receiving the protective factors training, we have about 75 certified trainers around the state of Colorado to deliver that training. There's 7 modules and they're each about 2 hours long. So if you're interested in having it trained in your community or your organization, let us know and we can connect you to that network of trainers that can come out to you.
Thank you all for those really interesting presentations. To the audience, we have a couple minutes, so please feel free to put questions in the chat box. There is one, I think, specific to sort of to Colorado families with children with developmental disabilities and whether there's a way specifically to help connect with resources. So I don't know if Erin or Esmeralda, if you have things you might want to put in the chat box. So I'll start off with a question. We often have a lot of students and trainees on these calls, and I'm curious to know for all of you, whether there are opportunities for engagement as students and trainees in the work, whether through research or practicum opportunities. Erin, how about you first?
You cut out on me. I thought you were asking me a question, but could you repeat your question?
Oh, so sorry. Yeah, the question was whether there are any opportunities for students or trainees to get involved, either through research or in a practicum context.
Yeah, for sure. So we partner a lot with the universities when we are doing some research around our programs. So there's some opportunities there, but we also bring interns into the office. We had one this year. I think we're going to have 2 next year, but we certainly welcome and would value anybody that has some interest in receiving more training or coming in to participate as an intern in any of our programs.
Wonderful. Thanks. Go ahead.
As I say, if they want more information, you can just contact me, and if it's not in our unit, we'll get you connected to the right one. So
wonderful, thanks. And Hector, curious for you if you have any opportunities for students or engagement in research.
I always do. So I share my email with you, so feel free to share it with whoever might be interested. Again, I'm always recruiting students into my program, especially those that are, or postdocs. Right now, I have every position filled, but I'm always interested in talking with prospective either students or postdocs.
Great, thanks. My next question, also I think for both of you, Erin, maybe I'll turn it to you first. So we're in this odd phase, right, where we've just come through this, I think, pretty horrific pandemic period. And it sort of feels like things are going back to normal, but they're not really yet. And I think we all know that there's going to be a long haul still in terms of, families facing a lot of stressors and kids being sort of in this like between period. It feels like they're sort of back at school, but then their families are going to be under a lot of stress too. So my question for you is, if you had a magic wand for 2021, what would you do to sort of get us back on track and hopefully mitigate some of the effects of the pandemic? Policy, money, anything you want.
money. No, in reality, we would certainly want to figure out a way to expand the 5 protective factors, at a state level, at a community level, at a family level, because we know that they work. The research shows that it works. We show that families do better when we can increase those characteristics. But probably my biggest wish is that we would take, COVID was difficult for all of us, but there's also some learning in there, so that we take what we learned from that and we figure out how to provide our services in a way that's more meaningful and that it really meets the family's needs. Probably the best example that we can give is, a lot of our programs did to encourage virtual visits, and as the nation was shutting down and we went to this social distancing piece, we figured out how to make it work. And the families are actually telling us, like, we would kind of like a balance of that virtual piece versus coming in piece, because they get to spend more time with their children. So I know there's going to be many more learnings that we can bring out of COVID and not focus on the negative, but on the positive. So how do we figure out how to capitalize on what we did learn and turn it into a positive? So that would kind of be my magic wand.
Wonderful. Hector, how about you? You get a magic wand also.
Oh, that's very complicated. I'm going to be very pragmatic. I think some healthy space is going to be necessary. So, for instance, my daughter, she doesn't want to go back to school, and I'm assuming that there's for the desire is different. But I think for those home environments that might be more challenging, creating space, sending the kids back to school if it's safe, it's going to actually lower the burden of stressors at home and work in kids' behalf. So as we think about, right, how do we get our children back to school? For a lot of families, this is not only because of the meal supplements, but also because of the complexity of those home environments. That might be an additional incentive to hurry up and vaccinate and get everybody back to normal, right? I think lessening the social burden on families of being packed in us, especially in socially economically disadvantaged communities, there's bigger burden on homes, right? The households are bigger, and so I think going back to normal, sending kids back to school, sending people back to offices might help with that. So again, it adds this one additional perspective on how we're seeing our way back to normal.
Yeah, wonderful. Thank you. There's a question in the chat box that I think is for the Colorado crew. If you could talk maybe just a little bit more about some of the culturally tailored programs, and specifically in foreign-born families, like Latino families in Colorado, and early home visiting.
Man, you got the right person here. Esmeralda is leading our EDI work for our unit in our office, so I'm going to let her take that one on.
So that is a great question. So currently across the office, there are, I'd say, over 30 equity, diversity, and inclusion initiatives, one of which includes, and I'll speak specific to the early intervention team, in one really looking at the data or the demographic information that is gathered and reported back to our federal partners, and really making sure that we're tracking the race and ethnicity accurately, as well as primary language spoken at home. So there is that component. As it relates to the delivery of services, there is currently a work group that is convening with early intervention around the practices that are currently in place culturally responsive? How can we ensure that they are, especially when looking at cultural contexts across families or within a family, that there may be protective factors around that social support or connections, or there may be because of the newcomer status, they may not have that kind of community support. So that is something that we're looking at within that. So please feel free to email me. I can provide additional examples. Because there was a question specific to Latinx teen parents. Because I'm not within that unit, I'm not sure that the demographic data that we are collecting is broken down to that level. So I'm happy to also answer that further through email.
Great. Well, thank you. All right. Well, we are right up at the top of the hour. So I want to remind our audience, we will be sending out a link to the webinar if you want to share it, watch it again, catch any of the points that you might have missed. And we'll be sending out an evaluation too that we hope people will fill out. We hope you'll join us in July for our next webinar, which is going to be on, let's see, July 13th, focused on ski-related injuries, ski and snowboard-related injuries. But thank you so much to all of our presenters today for sharing your time with us and your wisdom. We really appreciate it and appreciate the work that you are out there doing. Thank you so much and have a safe summer.
Thank you.